again thank you all that you have invited me to chair free paper session. All three papers are from GMCH, and I hope we have an educational feast in the next 45 minutes to 1 hour. Thank you so much.
Before I proceed, I have three new people to introduce, three new joinings in our scientific committee. As we say, the beauty with brains, we would like to invite in our team Dr. Trupti Barot. Dr. Trupti is transfusion medicine specialist in Prathma Blood Center, Ahmedabad, Gujarat. Dr. Soumya Das, assistant professor and faculty in charge, Department of Transfusion Medicine, AIIMS, Nagpur. Dr. Anisha Navkudkar. Dr. Anisha is consultant, Department of Transfusion Medicine, Tata Memorial Center, Mumbai. It's indeed our honor and such a welcome to all three members of the scientific committee. They will be taking over charge of the scientific sessions from January onwards. And before I move forward, I hand over the mic to Dr. Mohammad Abubakar Rafi, along with our teams, Dr. Ankit Mathur, Dr. Suvro Datta, and Dr. Puneet Jain. At YPF, we are like fingers of the same hand. Now I hand over to you. I hand over all of you to the able hands of Dr. Mohammad Rafi.
Thank you, Aikaj, and welcome, Chairperson. Today we have three paper presentations. All the three are from GMC itself, GMC Chandigarh. Aikaj, you have stopped sharing your screen from your side.
Just a second, I'm so sorry.
So each person will be getting 15 minutes. So it has to be a consensus. Do we have the discussion after all the three or after each? Chairperson can tell.
Well, I would prefer, Archana, that we have the discussion just after the free paper, because having discussions for three free papers, I've gone through them, we would be missing on some vital points. So discussion wouldn't take much long, approximately 5 to 7 minutes for each paper. So if Archana is also willing with the same.
Okay, sir.
So we'll be having three people, like Dr. Siddharth Bhatia will be presenting on role of therapeutic phlebotomy in polycythemia. He'll be the first speaker, followed by Dr. Pinjari, who will be talking on assessment of serum iron stores in regular platelet apheresis donors, followed by Dr. Simranjit Kaur. She'll be presenting on profile of allogenic whole blood donors with delayed adverse donor reaction. So each of you will be having 15 minutes, followed by a discussion. So I call upon first speaker, Dr. Siddharth Bhatia, to go ahead and start sharing his screen.
Dr. Rafi, I would please remind you to just reconfirm the certificates part of this free paper session.
Sure.
If you could just tell everybody regarding the certificates and how they can get it.
Yeah, we'll be sending out a link in the live chat itself. So you'll have to fill that. And within 2 to 3 days, you will be getting the detail, the certificate in your email. The thing which you have to notice, whatever data, especially in the name which you're giving, that will be directly taken for taking your certificate. So the link will be shared soon. All the best.
Dr. Siddharth, please go ahead.
Thank you. Good afternoon, respected faculty and fellow colleagues. I'll be presenting a free paper presentation today on this topic entitled Role of Therapeutic Phlebotomy in Polycythemia.
You can just tap on your screen once, then start moving.
Polycythemia is a symptom of increased red cell mass. It is characteristic of several pathological conditions. Polycythemia can be classified into absolute and relative polycythemia. wherein absolute polycythemia indicates an increase in red cell mass and relative polycythemia indicates a decrease in plasma volume. Absolute polycythemia can be further divided into two types on the basis of the etiology. Primary polycythemia, which includes polycythemia vera, and secondary polycythemia due to hypoxemic conditions. Therapeutic phlebotomy has emerged as the treatment of choice for many, but not all conditions of absolute polycythemia. Therapeutic phlebotomy allows for a controlled and gradual decrease in the red cell mass and the serum iron. It is advocated for treatment aimed at symptomatic relief as well as prophylaxis of organ damage and thromboembolism. In polycythemia vera, lowering of hematocrit to below 45% leads to symptomatic relief as well as prevention of complications. And in polycythemia secondary to hypoxemia, lowering of hematocrit is advocated to between 50 and 52% so as to decrease the hyperviscosity symptomatic burden and confer protection against complications. There is a paucity of literature outlining the definitive impact of therapeutic phlebotomy in absolute polycythemias. So the present study was undertaken to evaluate the role of therapeutic phlebotomy in primary and secondary polycythemia. The aims and objectives of the study were to evaluate the role of therapeutic phlebotomy in primary and secondary polycythemia and to observe the changes in hematological and clinical parameters due to serial therapeutic phlebotomies. The study design, this was a prospective longitudinal study which was conducted over 18 months. For the sample size, a minimum of 25 patients who undergo therapeutic phlebotomy and give written informed consent were to be enrolled in the study. The patients undergoing phlebotomy were assessed for clinical and laboratory parameters and their correlations with clinical outcomes. The target hematocrit for polycythemia vera was chosen to be less than 45%. Until achievement of the target hematocrit according to the pathology. And the primary outcome of the study was change in hematocrit with serial phlebotomies. The secondary outcomes of note were clinical outcome with serial phlebotomies and changes in iron profile parameters with serial phlebotomies. The inclusion criteria was that the patient had to have an age of above 18 years, so an adult patient, and hemoglobin level of more than 16.5 grams per deciliter for men and more than 16 grams per deciliter for women. Exclusion criteria were if the patient was receiving cytoreductive treatment, if the time since last phlebotomy was less than 1 month, if the patient had poor venous access or previous intolerance, pregnancy, leukemia, and if the patient was unwilling to provide written consent. Upon enrollment, detailed history, clinical examination, and routine lab examination was undertaken. The patient was informed about the phlebotomy process, the post-procedure instructions, and possible adverse reactions. The baseline sample was taken for complete blood count and iron studies. After this, 350 ml of whole blood was drawn using a weighing scale. Post-procedure, fluid replacement was done orally or intravenously, depending on the condition of the patient. Patient vitals were recorded post-procedure, and a post-procedure sample was collected after 1 hour to see the changes after phlebotomy. Each patient was also followed up at 3 days after phlebotomy for the subsequent phlebotomy, till of course there was achievement of target hematocrit, and to assess the patient for post-procedure symptomatic relief. This was done using a 10-point visual analog scale, which was ranging from none, which was score 0, to agonizing score 10. Patient was also assessed for adverse events such as hematoma, wound infection, fatigue, hypotension, dizziness, nausea, and vomiting, and a complete blood count was performed before and after each procedure. The iron studies were only done at the time of enrollment and after achievement of target hematocrit. This was the visual analog scale which was used. So in this was a comprehensive visual analog scale, which also had Hindi letters in it for patients who had difficulty in understanding, and pictographic representation also of their condition. And they were asked to pinpoint on the visual analog scale how they felt about their symptoms. The results of the study. So 29 patients were initially assessed for eligibility, and 29 patients were taken up for phlebotomy in procedure 1. after which target hematocrit was achieved for 7 patients. 22 patients moved on to phlebotomy number 2 after being assessed for improvement. After phlebotomy number 2, there was a loss to follow-up of 2 patients, and 3 other patients achieved their target hematocrit. The remaining 17 patients moved on to procedure number 3. After procedure number 3, target hematocrit was achieved for another 7 patients, and 10 patients underwent procedure number 4, after which there was one more loss to follow up. 5 patients achieved target hematocrit, and 4 patients moved on to procedure number 5. 4 patients were also under procedure 6. There was no achievement of target hematocrit after procedure number 5. After procedure number 6, 2 patients achieved target hematocrit, and 2 went on further to achieve target hematocrit after procedure number 7, which was the last procedure. Demographics and history in the study. So there were 6% cases of primary polycythemia compared to 38% cases of secondary polycythemia. There were 38% cases of secondary polycythemia, whereas only 19% of the patients were female. Some of the other demographic parameters, the age recorded in this study had a mean of 49.88 years with a standard deviation of 14.473. The mean height was 169.81 centimeters with a standard deviation of 7.332. And the mean weight recorded was 62.23 kilograms with a standard deviation of 12.901. In this present study, 11.5% of the patients gave a history of having suffered a thromboembolic event in the past. 11.5 patients also gave a history of having suffered a CVS event in the past. 53.8% patients gave a history of hospitalization in the past, and 23.1% of the patients gave a history of having undergone a phlebotomy in the past. On the clinical characteristics of patient, the mean duration of illness was 18.9 months with a standard deviation of 20.465 months. The overall range of the number of procedures undergone by the patients was 1 to 7. None of the patients required more than 7 procedures. The mean number of procedures was 3. As we can see from this pie chart over here, 2/3 of the patients were able to achieve hematocrit in up to 3 procedures. Only 1/3 of the patients required further procedures after procedure number 3. Hematological parameters. So the change in hemoglobin at presentation and at target hematocrit was statistically highly significant. The change in hematocrit at presentation and at target was also statistically highly significant. However, the change in platelet count at presentation and at target hematocrit was statistically insignificant. In the iron profile, the change in serum iron at presentation and at target hematocrit was statistically highly significant, whereas all other iron profile parameters did not change significantly in the study after phlebotomy. In the clinical parameters, the change in score of almost all the clinical parameters was statistically highly significant. The only parameter where there was insignificant improvement was confusion. This was probably because it was a poorly understood parameter when discussing with the patients, and they were unable to understand exactly how to pinpoint on the visual analog scale regarding confusion. We also studied the correlations between some of the key parameters and number of procedures. So the pre-HB, the HB upon enrollment correlated positively with the number of procedures, and the post-HB correlated negatively with the number of procedures. Similarly, the hematocrit upon enrollment correlated positively with the number of procedures, whereas the target hematocrit correlated negatively with the number of procedures. In terms of platelet count, the platelet count, both the pre-platelet count as well as the platelet count upon achieving target hematocrit correlated significantly with the number of procedures. And in case of serum ferritin, there was a negative correlation between the serum ferritin and beginning the procedures and after achieving target hematocrit with number of procedures. On the clinical parameters front, we saw that redness of skin and burning, tingling in hands and feet were the two symptoms which correlated best with number of procedures. The incidence of adverse events increased with the number of procedures performed. The higher number of procedures led to weakness and bruising. These adverse events were managed in these patients with fluid replacement and choosing alternative venous access depending on the type of adverse event encountered. The thromboembolic and serious complications were seen mainly in patients of primary polycythemia. This is consistent with findings of Nevreker et al., and this is possibly due to an effect of increased leukocyte and platelet counts, which are also encountered in primary polycythemia. In our study, the mean number of procedures which were required for achieving the target hematocrit were lower than studies done by Lee et al. And Kong et al. In Southern Korea. But this is probably due to the fact that our interval was small and fixed at 3 days, whereas these other studies had a much larger interval. In this study, the hemoglobin was lowered effectively in all patients through red cell mass depletion. And the hematocrit was also decreased gradually by red cell mass depletion and expansion of plasma volume, which was also noted by Murugesan et al. In their study. The platelet count was not affected, and this is possibly due to the body's compensatory mechanism in response to frequent bleeding. The patients upon enrollment tended towards iron deficiency, and this was evidenced by the serum ferritin and transferrin saturation values, which were taken at baseline. After phlebotomy, there was a large decrease in serum iron concentrations because of the depletion of red cell mass and because of the increased bone marrow uptake for erythropoiesis. The serum ferritin levels and transferrin saturation levels were not affected, and so hence the phlebotomy did not cause any severe iron deficiency in the patients. Headache, pruritus, redness of skin, and burning/tingling in hands and feet were the severest amongst patients in the study. The greatest reduction in severity was found in redness of skin, followed by pruritus, headache, and burning, tingling in hands and feet. The decrease in RCM allows for a lowering of the hyperviscosity of the blood and also a consequent expansion of plasma volume, and this leads to improved blood flow, which leads to symptom amelioration. Some of the limitations of this study: the study was done on a smaller sample size of 29 patients, out of which 3 were lost to follow-up, and hence the data of only 26 patients was analyzed. A larger sample size study must be undertaken to draw final conclusions. The symptoms studied by means of visual analog scale scoring could be refined to include some of the more common symptoms. And a protracted follow-up post-achievement of target hematocrit is required so as to gain a better understanding on the effects of therapeutic phlebotomy after achievement of target hematocrit. We can conclude that therapeutic phlebotomy is a safe and efficient treatment modality for hematocrit control, symptomatic relief, and prophylaxis of thromboembolic events in patients of polycythemia. It is well tolerated, relatively cheap, and can be done with minimal equipment and resources on an outpatient basis. In this present study, a fixed volume of 350 ml was depleted at each phlebotomy. Even though this is on the lower side of the volumes usually depleted, when it combined with the regular and frequent interval of phlebotomy, it resulted in rapid and marked improvement. Significant amelioration was seen in most of the clinical parameters with serial therapeutic phlebotomies, and overt iron deficiency was not induced. These are some of the key references which were used for this study. And thank you YPF for allowing me this opportunity of presenting my work. Thank you ISTM as well. Thank you very much.
Archana, your views. I suppose I'll just put in a comment here that what I was told that the purpose of this presentation of free papers is that to have a clinical acumen, have a research acumen, how to correlate your research outcomes with your aims and objectives, how to statistically analyze them, and come to a conclusion which is clinically relevant. So with this comment, if I'm missing out on anything, it is not supposed to be a classroom teaching sort of a thing. in which we ask the normal serum ferritin levels, etc., etc. So I suppose with that perspective, I would like Dr. Archana to comment about this free paper from Dr. Siddharth Bhatia.
Thank you, sir. I have few questions regarding this study. My first question is, what was the basis of fixing the schedule of 3 days interval for therapeutic phlebotomy? Because what we practiced in our center is depends upon the diagnosis of the patient, whether it is primary or secondary, and subclassification of the secondary polycythemia, and what is the present hematocrit of the patient. Higher the hematocrit, more frequent is the interval. Then the second thing is, you have said that there is no association between the serum ferritin and the TP therapeutic phlebotomy procedures. But for hereditary hemochromatosis, serum ferritin is the marker for the follow-up of the procedures as well as to achieve the desired level of the serum ferritin through therapeutic phlebotomy. So what is your view in this particular group of patient and your experience?
Good afternoon, ma'am. Ma'am, I'll take the first question first. So, ma'am, because we chose volume which was on the lower side at 350 ml only, we decided to have a slightly more frequent depleting schedule of 3 days, as opposed to in literature, we found that some of the schedules would be up to 1 week, but most of them advocated every 2 days or bi-weekly. And some of the other studies that I had mentioned in this, the Korean studies, over there it was depending on the OPD schedules, and that would run into sometimes multiples of weeks. So because the volume selected was on the lower end, we decided on a more frequent schedule.
Okay.
And ma'am, secondly, ma'am, the serum ferritin did correlate with the number of procedures. It was just that it wasn't significantly affected in these number of procedures, ma'am, in our present study. As in to say that a significant amount of iron deficiency was not induced in the patients.
Okay. So one advice for you is that you need to more work on the formatting of the slides, on the font
Yes, ma'am.
size of the heading and the content. It should be more systematically presented. Thank you.
Thank you. Thank you.
Thank you, Dr. Archana. Um, may I request Dr. Siddharth to share his presentation once again,
Yes, sir.
just the aims and objectives slide.
Yes, sir.
Yeah. So there were two aims or objectives. First was to evaluate the role of therapeutic phlebotomy in primary and secondary polycythemia. So in your aims only, you have divided your polycythemia group into two groups, primary and secondary, right?
Yes. Yes, sir.
And then your second aim was to observe the changes in hematological and clinical parameters due to serial therapeutic phlebotomies.
Yes,
So
sir.
here, when you have given the results, you have
Yes,
not
sir.
actually, in any of your results, you are not talking about the results of whether it be demography, whether it be the parameters, whether it be any of the results. You are not discussing primary and secondary polycythemia differently. You have taken it as a whole. Let's see, come to the pie chart, that is slide number 10. Here you see that since you have analyzed the types of polycythemia on the whole, that is primary and secondary. Are you getting my point?
Yes, sir. Yes, sir.
So your aim and objective is not matching with your results. You must be having the data, but the analysis of the data, the interpretation of the data needs to be done according to the aims and objectives. That then you will be fulfilling the aims and objectives. Uh, that was one of the biggest flaw, or you know, the, the negative part of this study was, which was quite obvious. In Go to the next slides, one or two slides, your results.
Yes, sir.
Here also, you see, you have not divided it into primary and secondary, right?
Yes, sir.
So this does not fulfill your primary aim and objectives. Secondly, the second objective clearly states that you will look into the clinical changes also. What clinical changes you have taken into account?
Sir, I looked at these 9 symptoms, sir, and I looked at the improvement between the presentation with the amount that the patients complained about these symptoms using the visual analog scale upon presentation and the change after they achieved target hematocrit, sir.
I'd like to just make a brief point here that this VAS score is a highly commendable score. It is used worldwide, but they themselves, the people who made this score themselves say that this is very subjective. And as the symptom becomes more subjective, the score also weakens.
Yes,
So it would have been better that more objective parameters, like as you said in some of the previous slide, that history of hospitalization, any history of stroke, any other clinical symptom of hospitalization, or things like that would have been more objective in pointing out the clinical parameters post your first procedure of therapeutic phlebotomy. Um, this was second, and as Dr. Archana also pointed out, that serum ferritin highly correlates with the clinical symptoms, especially as she pointed out in hemochromatosis. But serum ferritin in your study is not at all being affected by, it is statistically not significant by the number of procedures, up to 7, and that too with a gap of 72 hours. So I am a little skeptical about this particular parameter, serum ferritin. I don't know what the other studies say, but as per our day-to-day experience, the serum ferritin is significantly lowered, maybe after 3 or 4 procedures only. But in your case, it is showing no statistically significant difference. That was another thing which I like to point out. And there was one question, last question in this, that um, except for patients of polycythemia vera, where malignancy is involved, what did you do with the bags of this therapeutic phlebotomy which you did for these patients?
sir, all of the bags, sir, all of this whole blood that was collected was discarded, sir, as per departmental SOP. None of the blood was used for any purpose, sir.
Can you be a little louder, please?
Sorry, sir. Sir, all of the bags which were collected, all of the whole blood which was collected was discarded, sir, as per departmental SOP. None of the blood was used for anything, sir.
Okay, okay.
Yes, sir.
So that's it, Dr. Siddharth. Good presentation, good effort.
Thank
But
you, sir.
just these were the few points which I wanted to point out. Thank you. Thank you so much.
Thank you, sir.
We do have some questions in the chat box too, Dr. Siddharth. Uh, One query is, what is the ideal time to check CBC after therapeutic phlebotomy? And a continuation to the same question, what is the maximum hematocrit and hemoglobin value after which one should undergo therapeutic phlebotomy?
Sorry, sir.
And there's one more question, what statistical test did you use for this study?
So the ideal time would probably be after 1 day or after a few hours. But since this procedure was done on an OPD basis, we had chosen of time of 1 hour after phlebotomy and after fluid replenishment and after the patient had recovered a little bit to draw the CBC sample. Hello.
And the statistical test also.
So the statistical test varied depending on the parameters that we were studying. So some of the normally distributed statistical tests, some of the normally distributed parameters were studied with the student C test, and the ones with the non-parametric parameters were studied with the Wilcoxon sign rank test. And for correlations, we used the Spearman's row correlation because the parameters were non-parametric.
Okay, thank you. So if chairpersons are okay, can we go to the next speaker?
Yeah, please.
Dr. Pinjari,
Yes, sir.
yeah, you can start sharing your screen from your side. We'll be talking on assessment of serum iron stores in regular cytopheresis donors. If anybody has any queries, you can put in the chat box or raise your hand.
Is it visible, sir?
Yeah, it's visible. You can make it full screen.
Okay, sir.
Yeah, go ahead.
Good afternoon, everyone. Special thanks to Young Professional Forum, and thanks to our HOD, Dr. Ramneet Kaur, for giving me the opportunity to this great platform. And today we will discuss the topic of assessment of serum iron stores in regular platelet versus donors. The iron loss following blood donation is caused 200 to 250 milligram of iron loss, average of 400 to 450 ml of blood. The resulting to mobilization of the iron from body stores to maintain the equilibrium. Iron deficiency is well documented in high frequency blood donors, while in platelet versus donors, there is apparently no loss of red cells. Donate at an interval of 48 hours and maximum of 24 donations in a year. During each procedure, the loss of the blood is 80 to 100 ml of blood. If the platelet persist donates at maximum recommended frequency, this leads to approximately 1900 to 2400 ml of loss yearly, equivalent to 4 whole blood donations. There is no data available from the India to address this issue in our platelet versus donor population. Hence, this study was planned with the intention to evaluate the serum iron stores in our regular donor of platelet versus donors. Aims and objects: to assess serum iron profile in regular platelet versus donors, to compare iron status of regular platelet versus donors with first time platelet versus donors and first time whole blood donors. Material methods. The study design is a case control study. The study period we conducted over a period of 15 months from the December 2018 to February 2020. The study population is included both voluntary and replacement regular platelet phase donors, and the first time platelet pheresis donors and first time whole blood donors for the control. The inclusion criteria: HB more than 12.5 gram per deciliter, age should be 18 to 60 years, platelet count more than 1,50,000 count, and weight is more than 55 kgs. And they have undergone at least 3 platelet pheresis procedure in last 12 months. Other standard donor selection criteria as per DGHS: exclusion criteria, history of whole blood donation in last 12 months, and failure to meet requirement of platelet versus donor. Other standard donor different criteria as per DGHS technical manual. Once the donor included in this study, he or she will not be included in further donation. These are the flow of the study. We take a total of 60 donors. We divide into controls and some cases according to their history of whole blood donation. In the last 12 months, we consider as not eligible. If there then platelet donation, 3 or more donation in the last month, last 12 months, we consider as eligible. Then screening of the donors done and meeting all the DGHS inclusion criteria. Then we decide the eligible persons undertaking written informed consent. Then we divide the 30 controls and 30 cases enroll. We take the sample before the procedure, 10 ml of sample taken, then divided into EDTA platelet sample. Hematological parameters with the EDTA vial. We done the hemoglobin, hematocrit, platelet count, and TLC, MCV, NCSH. I see. Then iron profile we take in the plain vial or centrifuge at the 3000 RPM for the 15 minutes. Then divide the sample serum, then done the amplifier. We consider the serum iron, serum ferritin, TABC and UABC, and percentage of saturation. Then statistical analysis among the cases and controls. Then we compare the study outcomes. Then end result is limitation, recommendation, conclusion. The results, the demographic characteristics, all 60 donors enrolled in the study were males. The mean age of the all donor was 27 years of age. The mean age of the cases and control group was 28 and 26 respectively. The 85% of the donors were aged between 18 to 32 years, and 56.7% of the donors were vegetarian and 43% were non-vegetarians. The 60% of the donors were voluntary and 40% were replacement donors. These are the hematological parameters. We can see the values of the all 60 donors. It comes 15 gram per cell deciliter. Then compared with the case and control, it always it's look same. There is no statistical significance in the all the parameters of the hematological parameters. You can see the hematocrit, MCV, MCH. They are all within range of the case controls. Then come to the iron profile. We significantly found the statistical significance in the three of the parameters, mainly serum iron and percentage saturation and serum ferritin. In a serum ferritin, we can see the cases and control values. Control values are 62.12 ng per ml, and the cases are 21 ng per ml. This shows the very high significant statistical results. We done the serum ferritin values comparing with the other hematological parameters. The serum ferritin, the cases and control was the 21.909 and 62.12. You can see the in diagram serum ferritin in the cases, it comes around the below around the 21. In controls, it higher than the cases. We divide the iron deficiency and depleted iron stores according with the iron deficient when less than the 10 ng per ml, and the depleted iron stores was within the 10 to 30 ng per ml. Out of 60 donors, more than half of the donors had serum ferritin less than 30 ng per ml. Out of these 34 donors, 25 were from the case group and 9 donors in the control group. It shows the more deficiency present in the cases group. Serum ferritin and number of annual donation. We analyze the donor annual donation. We observe the steady decline in the mean serum ferritin values of donors when there was an increase in their number of annual donation. Both the donors who had annual platelet donation of more than 12 times were found to be iron deficient in our study. You can see the here the more than 12 annual donation, there is a more deficiency present in the cases. These are the 3 times donation in the annual. These are the 4 to 6 and 7 to 9 and 10 to 12. Correlation of the serum ferritin and number of annual donation, platelet-based donation. You can see the graph. It going towards the. These we found a very significant statistical significance in the serum ferritin associated with the annual donation. Serum ferritin and number of platelet donation, lifetime platelet donation. You can see the first time donors, and 3 to 10, and 11 to 2, 11 to 25, 26 to 50, and 51 to 92. These are the p values of the donors according their lifetime donation. Serum ferritin values less than 30 mg per mml was observed all the donors who had their lifetime platelet donation more than 50 times. And while more than half of the donors were iron deficient when their lifetime platelet donation were 11 to 25. Depleted iron store were observed in the 66%. The value is serum value is serum ferritin 11 ng per ml, and then 40% and 25% and 28% of donors with lifetime donation accordingly the 51 to 92, 26 to 50 times, and 11 to 25 times, and 3 to 10 times. It shows the when more than 51 times of lifetime donation, in more serum ferritin deficiency is present. These are the p values of the donors. This correlation, we number of donation, we correlate the serum ferritin with the number of donation. There is no significant difference in the mean serum ferritin of first time donors and donor who donated 10 times. There was negative correlation of serum ferritin with number of lifetime SDP donation in cases, but this correlation was not statistically significant. And we compare with the donation interval, we observe the gradual rise in mean serum ferritin levels with an increase in a donation interval. And among cases, all three donors who had donated an interval of less than 2 weeks had iron deficient. The value is 3 mg per ml. Normal means serum ferritin. The normal range of serum ferritin was observed in one donor who had donated at interval of 13 to 17 weeks. The range is mean 46 ng per ml, and 4 donors who had donated interval of more than 20 weeks. The mean serum ferritin was 55.8 ng per ml. You can see the values in less than 2 weeks, less serum ferritin, and you can see the more than 20 weeks, the mean serum ferritin is more than the others. Then this is a donation interval, the p values of the according their weeks. Here in less than 2 weeks, p value is less than 0.05. So this shows statistical significant. In the more than 20 weeks, there is this is a more than 0.05 value. So there is no significant in the greater than 20 weeks. We compare with the age of the donors. We observed among cases, age was significantly associated with depletion of iron stores. The prevalence of iron depletion was higher as age of the donor advances. However, it was not linked to iron deficiency. You can see the values in the graph.
Only 2 more minutes.
Yes. We compare the serum ferritin HB values. A gradual increase in the serum ferritin was observed both in cases and control with increase in HB levels. Among cases, more than half of donors had iron deficiency in group with the HB level range between 12.5 to 13.5 gram per deciliter and 13.6 to 15 gram per deciliter respectively. A significant positive correlation was observed between HP and iron deficiency, and significant positive correlation was also observed between HP and depleted iron stores. We We compare the serum ferritin with their platelet count. There was a significant negative correlation observed between platelet count and serum ferritin of platelet versus donors. And all 4 donors with platelet count range between 3 lakh 1,000 to 4 lakh into 10 to the power 9 per liter had iron deficiency. Depleted iron stores were observed in the 62.5% and 33.3% of the donors with platelet count in range between 1,50,000 to 2 lakh and 2 lakh 1,000 to 3 lakh into 10 to the power 9 per liter. You can see the serum ferritin values in a platelet count more than 3 lakh. It means the donor having an iron deficiency with the more platelet count. So in the our
you have to pass enough. 50 minutes are over.
Okay, sir.
Try to conclude.
Then transfusion medicine specialists usually prefer to take double it of the platelet product from donor with a high platelet count. However, these donors may possibly be a threat of the having iron deficiency. You can see the graph coming down. We number of annual platelet donation on hemoglobin. We compare the platelet donation with the hemoglobin. Among 30 cases, the mean hemoglobin value steadily decreased from 15.50 gram per deciliter to 13.85 gram per deciliter, with increase in annual number of platelet donation from 3 times to more than 12 times respectively. There was a significant negative correlation observed between the two. You can see the annual donation had number of lifetime donation shared with the platelet donation. We observed steady decline in the mean HB value of donor, and there was an increase in their lifetime donation. There was significant relation observed only between HB values and number of lifetime platelet donation between 51 to 92 times. Overall, there was a non-significant negative correlation of hemoglobin base observed with the number of lifetime platelet donation among cases.
I think you should come to the discussion and conclude.
Okay, sir. Okay, sir. This discussion. Present study, in our study, controls had a higher level of serum ferritin, and in cases 21.09 mg per ml, it shows the significant decline of the serum ferritin in cases. So we concluded that our study shows statistically significant values according to our study, and these are the other studies. They shows the results of the study. There is a significant decline in Dugan et al. And decline at Salvin et al. And a significant decline at Lee et al. And a non-significant decrease in the Kim et al. Limitation: authors in previous studies have used different cutoff in defining iron deficiency. In absence of universal reference ranges, we were not able to conclude the precise scale of subclinical iron deficiency and depleted iron stores in regular platelet versus donor. Although most of our donors had serum ferritin less than 30 mg per ml, however, we could not apply this result on larger population of donor, as our study population was small. In addition, donor with prior history of whole blood donation was also included for the studies basing our study on the control group, and around 25 donors had serum ferritin less than the 30 mg. However, in control group, only 9 members of the donors had serum ferritin less than the 30 mg per ml. Regular platelet versus donors may lead to depletion of iron stores and therefore subclinical iron deficiency. Blood centers should pay attention to regular platelet versus donors with high platelet count, which may be associated with underlying iron deficiency, and deficiency of iron will be more in platelet versus donors because of greater tendency of extracting platelet from such donors. Hemoglobin prior to blood donation is a poor indicator of iron stores of donor. Therefore, assessment of serum ferritin in regular platelet and whole blood donors is better method of measuring the iron source of the individual. Next final. All donor in present study had hemoglobin more than 12.5 mg per gram per deciliter, and more than half of the our donor had serum ferritin less than 30 mg. Hence, we recommended determining the serum ferritin regular platelet donors at least once in a year in order to safeguard these donors who are donating life to others. In addition, regular platelet donors should be educated regarding iron replacement therapy as measure to mitigate iron deficiency in them. Since all donors who were donating frequency at least interval of 2 weeks had iron deficiency, hence we also recommended that there is need to extend or modify the interval of platelet donation, and further studies are required to ascertain frequency of donation in a year, so that red cell loss should not be more than the equivalent of whole blood donation. These are the references. Thank you.
Uh, Dr. Archana, any comments from your side?
Sir, thank you, Dr. Pinjar.
Yes.
You have done a very nice study,
Yes.
because
Thank you.
iron deficiency in platelet apheresis is very less addressed area. So
Yes, ma'am.
this type of studies are more required. My
Yes.
only point is, you have mentioned that blood loss is 80 to 100 ml.
Yes,
It
ma'am.
varies with the equipment, so it should be addressed that in which type of equipment how much blood loss is there, and what is the probability of having iron deficiency in that particular with that particular equipment. Then the other thing is the target yield, how making a double product causes more iron deficiency or iron stores depletion. So it is not correlated with, because once we collect the double platelet, then the interval is prolonged between the procedures, and each procedure loss equal amount of blood, whether it is a single collection or double collection.
Yes, ma'am.
Then
Yes, ma'am.
the technology of the collection, that intermittent flow technology or continuous flow technology is used. It will also creates a difference in the red cell mass loss, or as well as the hemolysis in the circuit. So this is also a point which need to be addressed. So
Yes.
it is a very nice presentation, and the data is very nicely presented. So thank you.
Thank you, ma'am.
Um, so, Dr. Pinjri, I congratulate you for a beautiful analysis part of this study. Uh, the analysis of this study is beautifully analyzed, but with uh, holding back or a negative point, that is, you have tried to interpret your data, the same data, in different ways, the same message being given by different graphs. So for putting this kind of a study in a publication in a journal is okay with so many graphs and all. But if you're presenting a poster or e-poster with a limited number of space, limited number of time, so you are not being able to give your message to the point, because you are presenting like serum ferritin with the number of donations, gap in weeks, gap in days. All the take home point is the serum ferritin is correlating well. That is, it is going down. Uh, this is as far as the analysis was concerned. Secondly, in, in your material methods, what are the parameters you had committed that you will be doing? I don't remember. Serum, can you just show me that slide, please? Yeah.
Materials.
These are the ends and objective. Material method, yes. Yes, next slide, please. Next. Next slide, please. No. So on what basis you have done serum ferritin and you have not committed these tests in your material methods.
We done only, sir, iron profile.
You have not committed. This is your aim and objective. Aim and
Yes,
objective would certainly be in a broader aspect, but
okay, sir.
in a material methods, you need to mention that what tests you will be doing,
Okay, sir. Okay, sir. Okay, sir.
right? Because most of the discussion is hovering around serum ferritin.
Okay, sir. Yes, sir.
So, as an audience, I had an impression that you did only serum ferritin and hemoglobin or hematocrit. So
Yes.
those are the iron studies you did.
Yes, sir.
So you need to be specific about what tests you will be doing to assess those iron studies,
Yes.
right?
Yes, sir.
So these were my few, and one good take-home message. I don't know whether Dr. Ravneet is there in this discussion or not. Aikaj, if Dr. Ravneet is there, she could comment on that more than
Mine is
50% of the cases and controls are below 30 nanograms, the ferritin. That's a very huge number.
Sir, Dr. Ravneet is amongst us.
Yeah, I am there, but Dr. Prashant, I have not looked into the study. Probably Dr. Gagan has, she was a main guide in the study, so I was not involved in it. Probably she'll be able to better give you the reply.
Okay,
She is there in the group.
okay.
We would request Dr.
We are
Gagan.
running out of time, so we'll pick up in some other forum. But this is actually alarming that 50% of the cases and controls Milake, it is less than 30 nanograms. That is the normal limit of serum ferritin.
She was looking into the study. I was not involved, so but she'll be able to answer that.
That's okay. That's okay, ma'am.
Thank you. Thank you.
Thank you so much. Thank you so much, Dr. Pinjari.
Yes, sir.
We have one question from the audience. It's which cell separator was used in this study?
Ameka, sir.
It's in continuation with ma'am's question, I think. Punjari?
Yes, sir. Ameka, sir.
Okay.
Yes.
Okay. So, chairpersons, can we go ahead with the next speaker?
Yeah, sure.
So I call upon Dr. Simranjit Kaur, JR3. She'll be talking on the profile of allogenic whole blood donors with delayed adverse donor reaction.
Good evening, everyone. Firstly, I would like to thank Indian Society of Transfusion Medicine and also our HOD, Dr. Ravneet Kaur, for providing us such an academic platform. Today, we'll be discussing about the profile of the allogenic whole blood donors with delayed adverse donor reactions. A blood donor can safely donate blood up to 10.5 ml of blood per kg body weight, which is well tolerated without experiencing any adverse reaction. But infrequently, adverse effects of varying and uncertain severity can occur either prior to, during, or at the end of the blood donation, which is causing discomfort to the donor, and these are known as adverse donor reaction. Immediate adverse donor reactions occurring at the blood collection site can be effectively managed at the blood donation site, but the main issue arises with the delayed donor reaction, which occur when the blood donors have left the blood collection premises. Such areas are often missed.
Go a bit slow, I think so.
Okay, sir. Okay, sir. Such areas are often missed and left undocumented due to lack of donor awareness and follow-up. Offset delayed areas are experienced by blood donors, but these are not reported to the blood center. For the aim and objectives, we analyzed the profile of allogenic whole blood donors who are experiencing delayed areas. Material and methods. The study was conducted in the Department of Transfusion Medicine, Government Medical College and Hospital, Chandigarh, after approval by the Institutional Ethics Committee and written consent from the donor. It was a cross-sectional observational studies, and study population consisted of the allogenic whole blood donors who were donating blood with the Department of Transfusion Medicine's GMC, Chandigarh. The sample size was 1845, which was statistically counted. Inclusion criteria: all allogenic whole blood donors which are meeting the eligibility criteria led by Drugs and Cosmetics Act 1940 and rules thereafter, which were amended in 1920, were considered. All allogenic whole blood donors experiencing adverse donor reaction after 15 minutes of removal of the phlebotomy needle. Exclusion criteria: all allogenic blood donors who were experiencing adverse donor reaction before blood donation, uh, and during blood donation and within 15 minutes of phlebotomy needle removal. Allogenic donors were screened as per the guidelines. From these eligible donors, prospective donors for the study were selected as per the random number of tables. Informed consent was obtained from such donors, and blood donation was done as per our departmental SOPs. The type of phlebotomy needle withdrawn was noted, and the donor was observed for any adverse donor reaction after 15 minutes of the phlebotomy needle removal. In case any adverse donor reaction occurred after 15 minutes, the details were recorded. And for the follow-up, 2 subsequent calls were made on day 2 and day 7 post-donation. A set questionnaire was asked from them. The non-responded term further used in a study will be used for the participants who didn't respond to the call when called at an interval of 4 hours in any of the 2 follow-up review days. This slide shows about the questionnaire which was asked to the blood donors on telephone, which mainly focused on asking about delayed bleeding, discoloration, which is a bruise, with any hematoma, arm pain, thrombophlebitis, any energy at the site, nerve involvement, fatigue, experience of generalized weakness, any fainting spell, or any other miscellaneous reaction they are reporting to us. Blood donors who approached us for the blood donation for 22,717, and those included were the deferred ones as per the screening criteria, which was 7,125. Eligible blood donors for blood donation were 15,572, and randomly selected for 1,845. And out of these 1,845, 14 were excluded because they were providing us with the wrong telephone number, and thus the total study population came out to be 1,831. This is graphical representation of day 2 and day 7 follow-up. For day 2 follow-up, all the 1,831 donors were called, and the persons who were receiving a call were termed responders, and these were 1,540. All these 1,540 were asked the SIT questionnaire, and out of these, 178 donors complained of experiencing delayed adverse donor reaction, which is about 11.6% of the study population. And in this case, the adverse donor reaction, which were off-site, occurred with a mean occurrence of 1.88 plus minus 32. Same as for follow-up date 7. All the 1,831 donors were again called, and the number of respondents here increased to 1,610 because 70 more donors were included who were earlier non-responders. And out of these, none of them experienced any delayed adverse reaction. These are the blood donor and blood donation characteristics of the 1,831 donors. The mean age for donors was 31.33 plus minus 9.6, with the median age of 30 years. Weight in kg, 74.71 plus minus 12.72 kg, with the median weight of 74 kg. BMI of these donors was mean was 26.03 plus minus 4.39, and the median BMI came out to be 25.71. Out of this population, majority of the population belonged to the age group of 18 to 30 years, which was 53%, and 98% were males, and the repeat donors constituted 68%. Delayed adverse donor reactions. Of these 1,831 donors, 180 donors, which is 9.83%, experienced delayed ADRs. ADRs when classified on-site and off-site. 2 donors complained of on-site delayed ADRs, which is constituting 1.11%, and rest 178 complained of reported of experiencing delayed off-site reactions, which is 98.89%. These are the demographic details and the donation, adverse donor details, reaction details of on-site delayed areas for the two donors. First donor complained of pain, arm, and numbness, while the second donor complained of generalized weakness, loss of consciousness, headache, which persisted for 4 to 5 hours post-donation. And these two, both the adverse reactions, they subsided or they recovered on day 7. These both donors were in their early 20s. They donated 250 ml of blood and they were first-time donors and male. Offsite delayed areas experienced by blood donors on day 2 follow-up. A total of 233 offsite areas were reported in 178 blood donors who responded when followed up on day 2 of their post-donation. 44, which is 24.71% of these 175 donors experienced more than one type of area. And there was only one donor who complained of thrombophlebitis, and he was needing some medical help from our side, so he was referred to surgery OPD for medicine for consultation. These are the demographic variables of blood donors who experienced delayed ADA or day 2 of follow-up. The median age was 29 years. Delayed reactions are seen higher, were reported higher in 18 to 30 years of population, which was found to be non-significant when p-value was counted. P-value using chi-square test was counted as 0.211%. 211. For taking for the sex, female blood donors were significantly found to experience more ADAs, delayed ADAs than male donors with a p-value of 0.004 using the chi-square test. Coming on to the donation status, among the blood donors who experienced the delayed ADAs on day 2, 50.2, which is 74 donors, were first-time donors, while 9.9% were the repeat blood donors. A significant association was found between the donation status and delayed ADA with a p-value of 0.220. Coming on the blood volume the donors have donated, no significant association was found between the volume of blood donated and the delayed ADAs. Coming to the next demographic variable, which is weight. The weight of the donors who experienced delayed ADAs lied in the range of 47 to 150 kg. The median weight came out to be 71.50 with an interquartile range of 65 to 81.25. It was seen that with an increase in the weight, the donors experienced less ADAs. Hence, a significant association was observed between the body weight and the delayed ADAs, which was statistically proved with a p-value of 0.11. Coming to the next variable, which is BMI, body mass index. Median BMI for blood donors experiencing delayed ADAs was 24.97 with an interquartile range of 22.55 to 28.20. Significant association of BMI with delayed ADAs was found, which was p-value of 0.038. Blood donors with BMI less than 18.5 were more likely to experience delayed ADAs than the donors who were having a normal BMI, which was 12.5 kg. Coming to the blood groups had no significant impact on the occurrence of the delayed ADAs. This is a graphical representation with a forest curve, which is showing us the correlation of demographic variables with the delayed ADAs when followed up on day 2. The demographic variables of blood donors associated with the occurrence of delayed ADAs were age, which was age between 18 to 30 years, which were having odds of 1.22 more vulnerability for a delayed ADA. Female female blood donors were 2.96 more vulnerable to experience a delayed ADA. First-time donors, and then coming to the blood donors who were weighing less between 45 to 60 kg, and the donors who had a BMI less than 18. This is again a graphical representation with adjusted odds ratio, which is about the delayed areas experienced by donors And here we came to know that it was female blood donors and the blood donors with first donation status and the blood donors with a BMI less than 18.5. Coming to discussion, delayed ADRs are often missed and left undocumented due to lack of duration criteria for differentiation between immediate and delayed ADR. There is lack of donor awareness and follow-up. We categorize delayed ADRs as the ADR occurring after 15 minutes of removal of phlebotomy needle, considering that blood donor remains at the collection site for at least 15 minutes after the blood donation. In our study, the risk factors for the development of adverse donor reaction, which were delayed, were young age, female sex, first-time donation status, low body weight, and a BMI less than 18.5. And these findings were in agreement with the other studies. The limitations of the study, firstly, it was a telephonic follow-up. Follow-up on day 2 and day 7 was based on the telephonic interaction with the blood donor, because of which 18.9% and 12% of the study population remained non-responder on day 2 and day 7 respectively. Secondly, there was a subjective interpretation. The nature of the delayed ADR was assessed by the subjective interpretation of the blood donor, and it wasn't objectively by the medical staff. This may have led to false reporting, underreporting, and overreporting of certain delayed ADRs, such as fatigue and generalized weakness. Conclusions. Delayed ADRs do occur after the blood donation has left the collection site. Delayed ADRs can have a negative impact on the donor return. It is important to have an insight into the risk factors and track them. At last, these are the few of references used. Thank you.
Thank you,
So,
Dr. Simranjit. Dr.
yeah, Archana,
Simranjit,
please.
you have done a very nice study. Again, it is a missed part and unnoticed and undocumented.
Yes, ma'am.
And it definitely affects the donor return rate. So it should be properly taken care of. Delayed adverse donor reactions. I have only one question, that
Yes,
majority of your delayed reactions are bruises, hematoma, and the pain at the phlebotomy site. Do you think that it is related to the training of the phlebotomist or the experience of the phlebotomist?
Yes, ma'am, it is also related with the phlebotomist experience also, because sometimes we are drawing the blood and it is not coming freely. So we are manipulating the needle. The needle manipulation can lead to various other delayed areas such as pain arm or uh, like or when your needle is uh, puncturing the other site. It can lead to delayed hematomas, or sometimes it is donor characteristics also. The donor care, the donor is not having a proper care at the phlebotomy site. Even you tell them to compress the phlebotomy site after the blood donation, they are like we need to have a more donor awareness. No proper compressions are given and such things.
Right. Okay, thank you. Over to sir.
Yeah, thank you, Archana. Dr. Simranjit,
Yes, sir.
first of all, I would like to certainly congratulate you to pick up such a topic which has been dealt with not in larger perspectives, especially in Indian scenario where less of manpower, less of expertise is available vis-a-vis in Western countries where you get a transfusion nurse assigned to each and every donor once he or
Sir.
she enters the blood bank till he or she walks out of the blood bank. So certainly this is a topic which has not been dealt much with. Uh, as a research paper, looking at that as a research paper, I have certain queries and comments.
Okay, sir.
First is um, the selection of these donors. You said that the donors were randomly selected. What was
Yes,
the
sir.
criteria of randomization?
So every 7 donor who was coming for blood donation with us was selected to be the part of the study, whether it was in camp or in house.
Okay.
They
So
were taking,
every 7 donor, whether
yeah,
male, female,
or a female, no
or
irrespective of any criteria, just only a 7th donor, whether he was coming for an in-house donation or whether he was coming in the camp. So I tried to like get maximum postings for the camp where I can get maximum of the enrollments.
right. So this leads to my second question.
Okay,
That
sir.
since you have done your study 15 minutes on site, after 15 minutes on site,
Yes, sir.
second is day 2. Uh, Day 2, that is first call, and after 4 hours, second call. Day 7, first call, and after 4 hours, second call.
No, sir. We were having 2 days for the follow-up. First was day 2, and the second was day 7. Firstly, I was making a call to a person. In case he is not responding to my first call, I was ought to make a second call to him after an interval of 4 hours. So I can like, he can be a responder for me. He can give me information about the delayed area if he is experiencing.
Yes, that's what I'm saying.
Unless,
That's what I'm
yes,
saying. That's what I'm saying. Ki
okay, sir.
If the patient, if the donor has not responded, then again a call after 4 hours.
Yes, sir.
And you have randomized and taken this sample, the donor sample, I mean to say, the N of your study,
Yes, sir.
in a constant manner, if I am not wrong, from December 2018
No, sir.
to
January 2019 to the end of the year, like for the
January,
whole year,
1 year.
2009, 1 year.
Okay. So how did you maintain the logistics of, the list of donors who are supposed to be called today, because overlapping of the donors
Yeah,
on day 1, day 7 would be
yeah. So there was a huge, like, it was a cumbersome issue, but I made a tabular form in a worksheet where I was writing the camp date or the donation date and the second call, which is to be made. I made a 2 column for that, day 2 and day 7. And I used to write dates in day 2 column and day 7 column so that I can have an idea which donor numbers, which donor series is to be called on day 2 and which donor series is called to be on day 7.
okay.
So I was daily maintaining a chart of this. And I was entering these all the demographic details in an Excel sheet.
Fine, fine. Because this is a Herculean task to maintain, because lot
Yes,
of
sir.
overlapping and this and that. My another query or inquisitiveness, you would say, is that
Okay.
on site 15 minutes there were 2 donors who reacted, right?
Yes, sir.
And you have recorded their blood group.
Yes, sir. Actually, we were getting the demographic details of all the donors. So I think it would be not, I shouldn't leave these 2
You feel
donors.
actually blood group affect the adverse donor reactions.
No, sir. It was found to have a
That's what I wanted to
non-significant.
highlight here, that don't give unnecessary data or unnecessary things for a poster judge or for a chairperson or for that matter a reviewer to jump
Okay,
upon.
sir. Okay, sir.
There was no need.
Okay, sir.
There's no correlation between blood groups. There might be a correlation. There have been 101 studies on blood group correlation with 101 diseases and everything. There
Yes, sir.
might be, but scientifically speaking, you know it, that that is not relevant to your study. So
Yes, sir.
don't do things which are not relevant,
Okay, sir. I will take care of it from next
right?
time.
And I have also conducted one of these studies, prevalence and predictors of donor reactions in platelet-pheresis donors,
Okay, sir.
and recently published. So my point here was that I also concluded that female donors, young female donors with low blood volume, large ACD, and intermittent procedure leads to high reaction rate. So
Yes,
your conclusion is well taken, and I think it would be in line with other studies on this topic. So
yes,
thank
sir.
you for a wonderful presentation, Dr. Kaur.
Thank you, sir. Thank you, ma'am.
I think we have only one query from the chat box. Why is the normal eligibility set to 10.5 ml per kg per body weight.
Sir, this is per the ABB guidelines.
Okay. Now all over to Dr. Aikach.
Thank you all for such a wonderful academic program. I would ask the honorable chairpersons for their concluding remarks. And before we call it a day, I would request Dr. Archana Bajpai for her concluding remarks.
Thank you, Dr. Ekaj, and all the presentations and all the residents have taken a very good effort and they have done a very good job, and keep it up. That's all. Thank you.
Thank you, Dr. Archana Bajpai. I would request Dr. Prashant to say a few words as a concluding remark.
Yeah, thank you, Ekaj. And once again, thank you, Young Professional Forum, for giving me this opportunity and responsibility of chairing this session of free papers. This is a wonderful initiative, which I think should go a long way in association with Indian Society of Transfusion Medicine. All three papers were well designed, well executed. The studies were well executed. Conclusions were well concluded. We have not, because of the paucity of time, obviously we have not been able to delve into the what was the basis of statistical analysis and things like that, which are very, very relevant for any research. So on the whole, I really enjoyed this session of 1.5 hours, and I would wish all of you young people, all the best for the future. Thank you.
Thank you, sir.
We thank both the chairpersons. We thank the speakers. I personally thank all the YPF team, including Mohammad Abu Bakr Rafi, Dr. Ankit Mathur, Dr. Suvro Datta, Dr. Puneet Chen, myself included. In the same breath, I thank the new scientific committee, which will be joining us from January, Dr. Trupti Barot, Dr. Soumya Das, and Dr. Anisha Navkutkar. We have a very strong presence on social media. All the recordings of all the webinars, free papers, and journal clubs are uploaded for free on our YouTube channel. Please like and subscribe. And also, please follow us on our Facebook account for regular updates of our upcoming events. I, on the behalf of the entire young professional fraternity, wish you all a Merry Christmas and a very Happy New Year. I cannot wait for this 2020 to be over. Thank you all for your time. We'll be ending this meeting now.
Thank you, sir.